Well, live, sir.
Good morning.
Good morning. Shall we start?
Yes.
Yes, sir. Yes, sir.
Yes. So, good morning, one and all, and I welcome you on the behalf of IIP Delhi office in this fourth eNephro masterclass session. And today's session is on hydronephrosis. And we have a esteemed faculty from Malaysia, Dr. Uh, Thalgaonkar, and along with we have an expert, Dr. Selva and Dr. Manish Kumar. So welcome you all, and thanks Dr. Neha to conducting this wonderful session. And now I would like to invite our president, sir, Dr. Ajay Gupta, sir, to say a few welcome words, and then we'll start the session. Hand over to Dr. Ajay, sir.
Thank you, Dr. Dinesh. Good morning, respected faculty and dear delegates. We are today joined by eminent faculty from India as well as from abroad. We welcome Dr. Ranjit THERGAONKAR, Surgeon Commander in Navy, Indian Navy. We welcome you, sir. And we are also joined by Dr. Selva, who has joined from Malaysia, especially for this. And he is the Deputy Director of the Institute and Nephrology Department. And Dr. Manish Kumar, he is the former director of Chacha Nehru Bal Chikitsalayah in Delhi. And he is now the nephrology department in charge at Super Specialty Hospital in Noida. And we thank Dr. Neha for organizing all these sessions very nicely. Without wasting much time, because obstructive conditions which can lead to hydronephrosis is one of the major causes of chronic kidney diseases in children. So if treated well in time, the condition can be reversed. So without wasting much time, I request Dr. Neha Bhandari ma'am to please take over.
Thank you, sir. I would like to thank IIP Delhi, Dr. Ajay sir, Dr. Dinesh sir. It is so amazing to see all of them, both of them working so hard. And would like to thank all our delegates also who have joined this early morning. So I would like to first of all welcome Dr. Manish Kumar. Sir is a very, very renowned pediatric nephrologist. And I think he's one of the persons who has actually written the guidelines for hydronephrosis through ISPN. So welcome, sir. I would like to welcome Dr. Selva, who is again an expert with us today. And sir is a very renowned person in IAP also, as well as pediatric nephrology also. So he's currently in Malaysia, and he's a deputy dean of Academic and International Affairs, Faculty of Medicine, Asian Institute of Medical Science and Technology at Malaysia. He has also been a consultant pediatrician and pediatric nephrologist. He's interested in nephrourology. He has also been a part of various international organizations. So welcome, sir. I would like to welcome our speaker, Sir Dr. THERGAONKAR. So he's a surgeon commodore, which he's just recently told me it is equivalent to a brigadier. So sir is a very, very renowned pediatric nephrologist. He's a dean director, Institute of Naval Medicine, INHC. Ashwini, he has held various positions in various important organizations of Navy. Professor and head of Department of Pediatrics, INHS Ashwini, professor and head Department of Pediatrics Command Hospital, Kolkata, and commanding officer at INH Sanjeevani, Kochi. His areas of interest are nephrourology. He has also won a lot of awards, especially ISPCon 2015 Best Paper Award. He has written various international as well as national papers, as well as editor of various chapters in various books. Welcome, sir. And we'll start the session because all our delegates have requested that we delegate more time for question and answer. So I would really request to kindly try to summarize the talk in half an hour. Thank you, sir. Over to you. Ranjit, sir, you can start.
I'll just start again. At the very outset, I'd like to thank IIP Delhi, Dr. Ajay Gupta, Dr. Dinesh Goyal. I know it's a busy Sunday. It's also a day on which a lot of NRP training is going on. And thank you for dedicating your time to pediatric nephrology. Thank you, Dr. Neha. You've been the sheet anchor of this entire academic series. Honored to share the stage with Dr. Selva Kumar and Dr. Manish. Coming to the topic, hydronephrosis in children, I'll try to keep it simple in a case-based approach. I think now my slide is not progressing. Okay, yeah. So this is a typical case which comes to us in the outpatient department. This is a 30-year-old lady. She is in her third pregnancy, and the ultrasound reports that there is a pelvic calyceal system dilatation, which is about 8.2 mm, and the parents are worried what is going to happen to the baby. The pediatrician, the gynecologist is confused. They send it to pediatrics, sometimes to pediatric surgery, and this dilemma is understandable. So the most important thing is that we have to ask ourselves some very basic questions: that how do we read this USG report? How common is antenatally diagnosed hydronephrosis? What can be the causes? And how do we follow up such a case? So first things first, what is the most important measurement in antenatally detected hydronephrosis is the renal pelvis AP diameter, which is measured at the level of the renal hilum. And we can see over here how it is being measured. Now, this is the single most important objective measure of hydronephrosis if a number has to come into play. However, there are other important findings also. So as we can see, the cutoff is 4 mm in the second trimester, 7 mm in the third trimester, and previously 7 mm, but now revised to 10 mm as per the UTD classification. Now, this 7 mm and 10 mm is a bit of a dilemma for many of us. But suffice it to say that 7 mm is much more sensitive and 10 mm is much more specific. And that's why 7 mm during the third trimester and 10 mm after the delivery is considered more useful cutoffs. Then we should see whether there is any calyceal dilatation, whether it is central or whether it is peripheral. We should have a look at the parenchymal thickness. What is the appearance of the parenchyma? Are the ureters dilated? How is the bladder appearing? And is there any unexplained oligohydramnios? So the amniotic fluid index should be above 5 to 7. So these are some important signs which can sometimes, give us a clue towards the diagnosis of the patient. This very famous keyhole sign, where the upper circle denotes the bladder and the lower smaller circle denotes the dilated posterior urethra, is considered pathognomic of posterior urethral valves, but can occur in other lower urinary tract obstructions. If we see a dilated ureter right next to the bladder, that means that there is some kind of an obstruction which has happened. At the level of the kidneys, if we see such a large echogenic focus away from the kidneys, that urinoma, it is quite ominous. About 70 to 80% of such kidneys may not be functioning, especially so in the second trimester. Now, there are 3 classifications of antenatally detected hydronephrosis. One is, of course, very simple, based on the renal pelvic AP diameter. So we have cutoff of 4 to 6 mm for mild in the second trimester, 7 to 10 mm in the for moderate in the second trimester, and more than 10 mm in the second trimester for severe. In the third trimester, this shifts to 7 to 9 mm, 10 to 15 mm, and more than 15 mm. So these numbers of 10 mm and 15 mm become important to say that it's, of course, severe. There's also a SFU classification. I'll be coming to this later with the help of a figure. But what we can see is also the newer classification, which is called the UTD classification, where the features which were reported previously, peripheral calyceal dilatation, abnormal parenchyma, thickness or appearance, the ureters being dilated or even being visible for that matter, abnormal bladders or unexplained hydronephrosis also come into play as a part of the standard reporting format. And so any of UTD A2 or 3 requires more close follow-up. This we all very often get an SFU classification, and we can get confused on this. So in SFU1, the urine is barely splitting the pelvis. If it is SFU2, it is that it's divided into 2A and 2B. So there is moderate renal pelvis splitting confined to the renal border with dilated major calyces, and sometimes it can be beyond the renal pelvic border with major and minor calyces dilated, and the parenchyma is paired. This is called SFU3. And if the parenchyma is thinned out, then it becomes SFU4. We should not forget to look at the report outside of the kidney also, because there can be soft markers which are present in other systems: ventriculomegaly, choroid plexus cyst, hypoplastic nasal bones, thickened nuchal folds, intracardiac echogenic focus and echogenic bowel, shortened humerus, shortened femoral length, and single umbilical artery. All of them can indicate that there may be an aneuploidy present, and then we need the help of the geneticist. So how common is antenatally detected hydronephrosis? All depends on the individual studies being carried out, but a ballpark figure which is easy to remember is 0.5 to 5% of all pregnancy, and it is the most commonly detected antenatal anomaly. So this is why we do get a lot of referrals for ANH. What are the causes of antenatally detected hydronephrosis? The most common cause is the transient hydronephrosis. Obviously, since we know that such a hydronephrosis resolves on its own, it's usually not followed up with more investigation, and therefore a specific etiology is not assigned to it. But suffice it to know that it's going to resolve in much more than 50% of the cases, and in some series even more than 80% of the cases. But uretropelvic junction obstruction, vesicoureteral reflux can account for 10 to 20 or 10 to 30% of the cases. Megaureters, sometimes multicystic dysplastic kidney, though not strictly hydronephrosis, is the actual finding when a definitive ultrasound is carried out. Lower urinary tract obstructive conditions such as posterior urethral valve, urethral atresia, uretroceles, they can account for a small minority, but then these are the small minority of cases where we must act with speed, detect early, investigate early, intervene early. Now, how do we follow up such a mother? So now these are the IAP guidelines, the standard treatment guidelines, STGs. So if it is unilateral, if it is mild, we can just go in for a third trimester ultrasound and nothing much more. If it is bilateral or it's a little severe, if any of these abnormal findings are there, then we need to follow up every 4 to 6 weeks. If there are significant extrarenal anomalies, then of course, as we discussed, we need to go to specialized centers. Now, once the baby is born, what do we do? First question is, do we need to give antibiotic prophylaxis? As per the ISPN 2023 UTI guidelines, not required, because the benefit has not been demonstrated by any evidence. There was a large PREDICT trial which did not show the much benefit. If the renal pelvis AP diameter is less than 7 mm, then it's not even hydronephrosis. We can reassure the parents. However, we can tell them to repeat the ultrasound after another month or maybe after another 4 to 5 months, depending on how it is convenient. If, however, there is mild or moderate hydronephrosis, but no other ominous features, then the ultrasound can be repeated more frequently. Again, if we find on follow-up in general that there are 2 ultrasounds serially which show that the kidney is normal and there's been significant interval between these 2 ultrasounds, then we can even we can reassure the parents and stop the follow-up. Now, when should the more important question is, when should the first ultrasound be done after the baby is born? We don't have to do the ultrasound immediately on the first day of life. We have to wait for the baby's breastfeeding to pick up. As we know, the babies lose water in the first few days of life. Breastfeeding is not well established in many children. And usually it is wiser to wait for 3 to 7 days when the baby is adequately hydrated, and we can be more sure of the ultrasound finding. However, if we feel that there is any lower urinary tract obstruction, these features, as we are nominated, at the cost of repetition, peripheral calyceal dilatation, abnormal renal parenchymal thickness or appearance, dilated ureters, abnormal bladder, if any of these findings is there, then it is severe hydronephrosis, and then the ultrasound has to be done within 48 hours, and we must go in for a micturating cystourethropography. If we feel that we are quite sure that there is lower urinary tract obstruction, then we should try and do it within the first 48 hours of life. In case it is something else, we feel it's likely to be something like reflux, then we can wait till 4 to 6 weeks of life. Now, if the MCU is normal, then we can think that there may be something like pelvic junction obstruction, and then we can do a diuretic renography. Now we do a EC renal scan, but we can wait for 4 to 6 weeks. We can wait even from 6 to 8 weeks, because we have to wait for the renal function to mature, and then this study can show an obstruction at the level of the PU junction or the UV junction. If, however, the ultrasound shows a vesicoureteral reflux, now antibiotic prophylaxis was written in the year 2022. However, now we are a little conditional about the antibiotic prophylaxis. It is required only for the high grades of vesicoureteral reflux, or if it is associated with bladder and bowel dysfunction, or if there is recurrent febrile UTI. Otherwise, it is not for all patients of VOR. If it is a PU valve, then of course we have to stabilize the baby, call in the surgeon, and then go in for a definitive intervention. If, on the other hand, the MCU and the EC renal scan are both normal, then it means that there is no obstruction. So we just follow up the child with ultrasound every 3 to 6 months. So I think this is an important algorithm which we need to keep in mind. So with this background, of course, we will close the first case. This mother had actually transient antenatally detected hydronephrosis. The measurement was again at, between 7 and 8 mm in the third trimester, and then on follow-up, it had resolved by the first birthday of the child. Now, coming to the next part, the next case. This is a 28-year-old mother, G2P1. The second trimester scan showed renal pelvis AP diameter of 5.9 centimeters on the right side and 4 millimeters on the left side. On the third trimester scan, however, when it was followed up, there is a borderline bilateral. I mean, 4 mm, we can say that it was unilateral or bilateral. But in all probability, this mother should actually have been given a more close follow-up, maybe 4 to 6 months weekly. But then there was direct third trimester scan where the dimensions actually flipped, where the right-sided renal pelvis diameter was 8 mm and on the left side it became 10 mm. Now, this baby was born preterm, and what happened was that the more importance was given to the prematurity of the baby, and the baby was taken into the NICU. And of course, after the feed was established and so on, the baby was discharged early on request, and somehow they forgot to do the follow-up ultrasound of this baby. The baby came to us after 2 months, and then over here, what we see is that there is a huge hydronephrosis on the left side, where it is reported as gross dilatation of the left pelvis, where the AP diameter is reported at 1.1 centimeters. And there's another interesting finding. There is abrupt tapering of the left pelvic calyceal system at the PU junction with no visualization of the left ureter. Now, this is again, experienced radiologists give this statement with a lot of conviction. And our algorithm, where we need to do an MCU first, is something which we may want to revisit, because very often in fact, more often than not, the MCUs in this case are normal and we don't find any reflux. At the same time, we've given a significant amount of discomfort to the baby. We've created the chance of a UTI itself. So this is something where, maybe the guidelines will be revised as and when the ISPN guidelines are revised. We may become a little less stringent on this requirement. Very interestingly, if we go in for a EC renal scan and we sit with our nuclear medicine colleagues, we can actually see the tracer going down and getting stuck at the PUJ obstruction. As and when that little tracer crosses the PUJ obstruction, we can even see whether there is an indirect reflux which is coming in. But then that requires patience, that requires us to sit with our colleagues, or at least pick up the phone and talk to them. So the point behind this, this case is that a dialogue between us and the sonologist, a dialogue between us and the nuclear medicine specialist is of immense value. So what should we do? Now, this is our algorithm. So, in pursuit of this algorithm, an MCU was done and it was found normal. And this was the renal dynamic scan of this baby. And I will take some time to walk you through this one. The first curve is what is called a perfusion curve, where we can see the tracer in the blood. And the left is shown with light blue and the right is shown with purple. And if we just follow the tracer, what we can see is that both kidneys are getting perfused quite well. Of course, this is the aortic curve, which is going to be very different. So there's a peak just before it enters the kidney, and then it kind of plateaus. Now, if we Now the same curve, when the nuclear medicine specialist puts the region of interest as the pelvis and then follows the tracer at this point, as we can see on the right side, there is a peak at around 2 minutes, and then this falls. Now, the important point is the point which we call T half. So when is the height going to become half of this? So if we see that it's becoming half of this at somewhere around 4 minutes, and then it goes down further, then the kidney is draining very well. That is the story of the right kidney. And this is called a type 1 curve. And if we follow the left kidney, then the graph is not going up so fast. In fact, the T max, the maximum height, is reached at 16 minutes, and then the T half is almost never reached during the course of the study. Now there are questions as to how long you should follow these scans. Can you do it after 3 hours, 2 hours, 1 day? But largely, if there is this curve, which is called a type 2 curve, where the T half is not achieved at 20 minutes. In fact, it is unlikely to be achieved after that. There is a strong indication of PUJ obstruction. We have seen amongst even pediatric nephrologists the question as to when to operate such a PU junction obstruction. Okay, before that, I will just show you the functional imaging. As we can see on the right side, the kidney is getting perfused quickly, it is filling quickly, and it's emptying quickly also. And on the left side, it is filling slowly, and then it is not getting emptied at all. So this is, of course, a clear-cut left PUJ obstruction. Now the question is, when should such babies get, or such children get, a surgery done? A lot of, since the problem is that very often we are not very used to looking at these EC renal scans, and we have to go for a number. And the number we select very often is the differential function. That if the differential function of the affected side falls below 35 to 40%, or if there's a deterioration of 5 to 10%, then we operate. However, this may not happen, and there may be a paradoxical increase in the renal function of that kidney, and that's why that criterion should be extended. As per, this is a very nice review article by Dr. Y.K. Sareen. He's a very prominent pediatric surgeon. So he says that if the T half is above 20 minutes, please think of operating, right? And if there is a very severe hydronephrosis, of course, the more important criteria, which is sometimes very clinically evident, that the kidney is palpable, where the renal pelvic AP diameter is above 3.5 centimeters. These conditions, without doubt, have to be operated immediately. This, of course, holds true for the more subtle cases. Other, indications: prolonged transit time, elimination indices, resistive indices on Doppler, plasma renin activity, biomarkers. These are under study, but of course, these are not a part of any standard guidelines. So that is about PUJ obstruction. The third case which I'd like to discuss is a case of a 2-year, 1-month male child. This baby was born to a 22-year primary gravida in a private hospital in a Tier 2 city. The antenatal checkup was essentially normal except for bilateral hydronephrosis. As we can see, the renal pelvic AP diameter was quite high. It was 23 mm on the right and 20 mm on the left side. Unfortunately, we don't see any other ultrasound reports in this. Other findings which we talk about: ureters, the minor calyces being dilated, the bladder findings, and so on. The baby was born at 37 weeks of gestation with a birth weight of 2.5 kgs. There is a history of interrupted urinary stream, but of course, this is what happened when they reported to the doctor and they asked, that's what came out. They came back also a bit late for follow-up to the clinic, where they found that the creatinine was elevated at day 5 of life. And this is the ultrasound finding, where there is a moderate hydronephrosis, there is hydroureterus, the bladder was also thick, and there are some floaters which were reported in the form of cystitis. So of course, the infection had to be treated. An EC renal scan was done. As we can see, that there was a type 2 curve on both sides at perfusion itself. But the bigger point is that there's no need to do a EC renal scan in such a case. This is the type 2 curve of both the kidneys, where it's plateaued. But the real issue is that it's quite obvious that there's a low urinary tract obstruction, and the EC renal scan was actually never required. And this is the more important investigation, the micturating cystourethropograph, where we can see a very broad posterior urethra. The more important thing is that the posterior urethra's diameter is more than twice that of the anterior urethra. So that is a very, very important finding. There is also a filling defect which we can see. And this is obviously a case of posterior urethral valves. So medical management was initiated. A catheter was left in place. We called in the surgeon who did a cystoscopy and fulguration. Now, again, sometimes it's not known that, it's not just about ablation of the valve itself and forgetting about it. These children are going to develop something which is known as a valve bladder syndrome, where initially the bladder is going to be hypertrophic. It's going to be the bladder, the sphincter is going to be dysfunctional. It's going to be very strong. There will be detrusor sphincter dyssynergia, and therefore there is the need for an alpha blocker and an anticholinergic to the baby, and regular follow-up, because it's not going to remain like that. After some time, the pressures plateau out, so it's no longer a high pressure bladder, and later on there is something known as a myogenic failure, and this bladder can actually become underactive when the child is 8 or 10 years of age. Now we have to manage the bladder actively throughout. So PU valve is a situation where the child has to be followed up over a period of time. So again, now when such a case happens and there is altered kidney functions, parents ask, and very often we also ask ourselves, that could something had been done when before the birth of the baby. So there are interventions such as vesicoamniotic shunting, fetal cystoscopies, repeated vesicocentesis. There was a randomized control trial, the Pluto trial, which occurred more than 10 years ago. However, when the sample size was 150, they were able to enroll only 31 patients, and the study had to be terminated prematurely because of a high incidence of amniocentesis and miscarriages. Even in those babies who benefited, there was some, largely most of them had improved survival. So they didn't, they survived the immediate neonatal period, but they landed up with CKD and on dialysis. So what can be done for such, can something still be done? So Ruano et al. Tried to further analyze the data from the Pluto trial and from other studies, and they said that there are various stages of lower urinary tract obstruction. In stage 1, it's very mild, and it's probably going to resolve on its own. At stages 3 and 4, it's quite severe, and the renal function itself is compromised. But stage 2, where there is obstruction but the renal function is preserved, that may be a good window where we can intervene. However, the concern here is that this is not an evidence-based statement actually, because there is it's not been this has not been justified by a randomized control trial. Outcomes can be better if the babies are operated between 17 to 26 weeks of gestational age, because the real concern is that of pulmonary hypoplasia. So yes, if we are able to do vesicocentesis, pulmonary hypoplasia is less likely. However, we are talking about the renal outcome here. So if we are operating at stage 2 of Ruano, if there are some observational studies which also say that if the urinary biochemistry is favorable, then we can go in for antenatal interventions. There are a few centers in the country which are giving these options now, but then it is best left to the experts. It's best left to refer such cases to the specialized centers and let them take a call, rather than us counseling the parents one way or the other. One more case, a 5-day male neonate, a case of antenatally detected hydronephrosis, asymptomatic. The urinary stream is normal at birth. However, they failed to follow up, and in fact, they didn't even have the reports. Now, this one ultrasound report with which they came to us, as we can see, it just talks about mild right-sided, mild hydronephrosis on both sides, and they've not talked about actual pelvic AP diameter. They've talked about the pre-void and the post-void residue, which is not very, the post-void residue is not very significant. But the most important thing is the renal pelvis AP diameter was not measured in this case. and the other findings which we talked about as per the UTD classification were not there. This baby, so there was, I mean, it was a bit of due this thing. From the medical side also, there was not enough of energy and initiative, and from the parent side also, thought they were lost to follow up. They came with the history suggesting recurrent UTI between the ages of 6 to 20 months. Most of these cases were actually undiagnosed fevers. In one instance, there is a positive urinary culture report, and therefore we believe that it was recurrent UTI. And an MCU performed when the child came to us closer to 2 years of age, showed grade 3 vesicoureteral reflux on the left side. As we can see, the urine is going up the ureter. However, it is not. It's going right up to the pelvis. There is dilatation, but there's not too much of tortuosity. So how do we manage vesicoureteral reflux? As we discussed, antibiotic prophylaxis is suggested if there is high-grade reflux. It may be considered if there is, for the low-grade refluxes, if there is bladder bowel dysfunction or recurrent febrile UTIs in an infant. The drug of choice is cephalexin in the younger infants less than 3 months of age, and later on we switch to cotrimoxazole or nitrofurantoin. Nitrofurantoin slightly more effective, but also at the cost of a bad taste and a slightly higher incidence of side effects. Cotrimoxazole slightly less effective, but lesser side effects. So they balance themselves each other quite well. Antibiotic prophylaxis can be stopped if the child is 2 years old, if the child is toilet trained and has had no urinary tract infection over the past 1 year. What are the indications for surgery if there is breakthrough febrile UTI despite antibiotic prophylaxis, or if the parents wish that they want surgery and they are very anxious? Coming to whether endoscopic correction should be done, endoscopic correction is very operator dependent and it's a very touchy subject with the pediatric surgeons, but the truth is that it is operator dependent, and then it remains between the doctor and the patient. What has come out through a large meta-analysis, of which the International Reflux Study and the Birmingham trials are the chief contributors, is that no intervention, be it antibiotic prophylaxis or anatomical correction, that is surgical reimplantation or endoscopic injection of a bulking agent, none of these interventions can prevent renal damage. None of these interventions can, I will repeat, prevent renal damage. So very often the patient is counseled that urine is going up the ureter and it's hitting the kidney. Now the reflux nephropathy, which we call as the scarring which is associated with VOR, if it has to cause renal failure, it will be very large scars which are present from before the birth, and this is a congenital scarring. Scarring due to UTI is very small and it does not affect the child so much. Not that we should not treat UTI, or we should try to prevent or at least treat febrile UTIs early, but they don't cause kidney failure. And the last and the most important thing is that sterile reflux by water hammer mechanism does not cause renal failure, definitely not after birth. That is what experimental studies have suggested. So that's why these are evidence-based guidelines from the Indian Society of Pediatric Nephrology. They are challenged very often from the surgical side, but I would implore that we all stick to these. What is the role of circumcision? Circumcision, as we know, has got non-medical, social aspects also. But the evidence does suggest that if there is high-grade VUR, then or there are recurrent febrile UTIs, then circumcision can help. Now, one last word is that as pediatricians, very often we see postnatally diagnosed hydronephrosis in India. Unfortunately, not much data is available, and chiefly it pertains to pelviureteric junction obstruction. Now, of course, and that makes sense because transient antenatal hydronephrosis would have resolved. Vesicoureteral reflux has a tendency to resolve as time passes. It does resolve on its own, and hydronephrosis is very often picked up on an ultrasound for being performed to something else like an abdominal injury or abdominal pain or something like that. Of course, transient hydronephrosis can be due to stones, and that is quite evident, and then that's beyond the scope of today's discussion. But what do we do with postnatally detected PUJ obstruction? Now, I attempted a systematic review. I also attempted a AI powered systematic review and was able to find very little literature focusing on this aspect. So this one study came in where even in this study, I would submit that um, there was a prenatal diagnosis still in majority of the cases, but still many cases of hydronephrosis were, in fact, were detected postnatally. So there were 174 renal units involved in this study. As we can see, mild UPJ obstruction accounted for the most of the cases, and severe was very few of them. If these children were followed up, most of the children showed resolution, more than 70% showed resolution over 30 months. And the single most important feature of persistence, association of persistence, was severity. So the single lesson we learned is that if the hydronephrosis is severe, then please intervene. Now, what is this intervention? If we speak with evidence, the evidence is not so much. But if we see that the kidney function is poor, now sometimes this does happen that they say that the kidney is showing just about 5 or 10% functioning, and is there even point? Sometimes people say that you should try to attempt a pyeloplasty. Sometimes you should. Some people say that okay, remove the kidney because it's going to create hypertension or recurrent UTIs. So what is usually done on ground is that if there is recurrent UTI because of that kidney, if that kidney is causing refractory hypertension, only then should that kidney be really removed. But that is not very common. That's in fact quite rare. If, on the other hand, the kidney function is very poor, an in-between trial can be tried where we put in a nephrostomy and look for an improvement in the renal function. And if there is if the renal function improves, then the PUJ obstruction can be relieved. However, there is no last word on this to the best of my knowledge. I'll quickly sum up today's presentation. There's a lot, I mean, it's a slightly busy slide, but it'll summarize. Antenatal hydronephrosis accounts for 0.5 to 5% of pregnancies. Ultrasound report should be comprehensive, reporting the renal pelvis AP diameter. SFU or UTD classification is preferable. In the second trimester, 4 mm. In the third trimester, 7 mm. Postnatally, 10 mm are cutoffs for hydronephrosis. For severity, 10 mm in the second trimester and 15 mm thereafter. Antenatal follow-up, third trimester if it is unilateral, or every 4 to 6 weeks if it is bilateral. I would say more than 50% are transient hydronephrosis, so we should reassure the parents who come to us. Postnatal ultrasound should ordinarily be done after 3 to 7 days, but more quickly if lower urinary tract obstruction is suspected. We should watch for the poor stream of urine or features of UTI and intervene early after birth. MCU is indicated if there is bilateral or severe hydronephrosis, or if there are any suspected features of lower urinary tract obstruction, also done in case of follow-up for UTI. And the cause is, of course, needless to say that the cause should be treated. With this, I come to the end of my presentation and bring greetings from a lesser known institute which I head now. It's called the Institute of Naval Medicine. It is the central repository of training and research in the Indian Navy. We train postgraduates, we train nurses, we train paramedics, and we also run a facility of hyperbaric oxygen therapy. On an unrelated note, it may be of interest to IPNs that we had published a book from the armed forces on early neurodevelopmental intervention. I stop here. Thank you very much.
Thank you, sir. Thank you very much for the wonderful session. I would request Dr. Manish, sir, your expert comments on this.
Yeah, thank you, Dr. Neha. At the outset, I must thank IAP for giving me this opportunity. So, Dr. Ranjit, it was a beautiful presentation from your side, and we all agree that this antenatal hydronephrosis, or we call antenatal UTD, that is urinary tract dilatation, is the one of the commonest congenital abnormalities detected on antenatal ultrasonography. And we do see the anxious parents coming to OPD with reports in their hand. But the good thing is that majority are transient. So one can remember a rule of third, that is 1/3 disappears even during pregnancy. By the time the child is delivered, there is no UTD. 1/3 becomes fine. There is no dilatation by 3 or 6 months or during follow-up. And the one third that remains is actually having uh, the different entities like this PUJ obstruction, VUR. But PUV is the most severe form of this UTD and needs to be detected very early so that intervention can be done at the right time. So one thing that Dr. Ranjit, I would like to add, or just what you just discussed, that antenatal these children with antenatal hydronephrosis, they don't require chemoprophylaxis. But if we see the predict trial, the children or this infants having high grade refluxes like grade 3, grade 4, or grade 5 refluxes, and without any episode of UTI, the predict trial did show that with antibiotic prophylaxis, there was a reduction in symptomatic UTI, though it did not affect the renal damage. So ISPN guidelines didn't mention about the chemoprophylaxis in the children because
Dr. Manish, you're totally right on this. Actually, the reason, as you are aware, was that the predict trial was not available at the time the guidelines were
right.
published.
Yeah. I just
Actually,
want. Yeah, I
so
was just coming on that.
and I totally agree with you on this. And
Yeah.
so, if for severe cases, we should, I think, consider antibiotic prophylaxis. Truthfully, I've
Even
burned my fingers on this in one case.
Yeah. So even before the child has an UTI episode, so children with high grade VUR, I think antibiotic prophylaxis should be added because the predict trial was published in 2023, and I think we came up with ISPN guidelines, and that was published online in October 2022,
That's
like
right.
that.
That's right.
So predict trial came later. So that was the reason. So one question I just wanted to ask you regarding this DTPS scan or LLECS scan. So on ultrasonography, it's clear that there is an abrupt narrowing of this PUJ, this pelvic junction, and looks like there is no ureteric dilatation. The bladder is also normal. So, what should be the ideal age? When should we advise DTPS scan? Should
So,
we go immediately or should we wait for 4 to 6 weeks?
so if we go in for a EC renal scan very early, the problem is that the kidney function, the GFR, is not yet matured.
Right.
So that is why the result of such a study would be fallacious. So we usually wait for 4 to 6 weeks. Actually, we talk more about 6 to 8 weeks before we
Right.
really do such a study.
Right.
And in the meanwhile, ultrasound is adequate to follow up the baby.
Right.
So if there is something very gross, more than 3.5 mm, then intervention can be done immediately also. But again, we know that pediatric surgeons are not very comfortable in operating in such young babies. So that's why there should be no hurry to do this EC renal scan.
Even if there is marked parenchymal thinning, and should we wait for?
In those cases, it can, very strictly speaking, actually, they do say that EC is a tubular agent, and therefore, actually, this rule was for DTPA, and they do say that EC is actually a tubular agent, and it can go out to the tubules also. And so therefore, in select cases, on a one-to-one discussion with the nuclear medicine specialist, we can go in for it. But then, what actually happens is that such a study, the indication for the pyeloplasty are not very crystal clear. So that's why we really, once we get the study, it may even be a valid study, but we really don't know what to do. If it is very open and shut, they can operate even directly. Or go in for a nephrostomy. So that's where the urologists come in.
Right.
And personally, I mean, Dr. Selva Kumar would, I'd request him to come in here. I think that urologists do very, all of them don't, many of them differ in their opinions. Yeah.
Okay.
I would agree. I mean, on that point, whereby if it's a severe hydronephrosis with parenchymal thickness, my colleagues here, they tend to do not nephrostomy. We can put a double J stent in and see and repeat the ultrasound and the nuclear medicine scan later if the function is better. That would allow us to do the pyeloplasty. Because especially when as Dr. Ranjit said earlier, if the function is less than, we take a cutoff point of less than 10%, we know that the outcome of the pyeloplasty wouldn't be good. But if some parents are anxious and just when we tend to do the double J stent and with the pediatric urologist and we wait and we repeat the scan. Would you do that actually, Dr. Ranjit?
I think so. In fact, yes, many of our pediatric surgeons go in for a DJ stent, and that actually seems to be a less invasive option. It can be left for 4 to 6 weeks, and in fact, that makes
after
perfect
4,
sense.
yeah.
That makes perfect sense.
By the time we will be available to do us the nuclear medicine scan. I mean, in my practice here, not many centers offer the nuclear medicine scan. So when we see this, by the time we order for the scan, eventually it'll be about 6 weeks postnatal, and it's just nice. If we do it earlier, the scan report is equivocal
Right.
or not supportive, and it's
Correct.
just
Yes.
rate. So they're making the parents more anxious. I mean, I would like to just touch on this posterior urethral valve, Dr. Manish. I mean, first of all, thank you very much to IAP, and also excellent lecture by Dr. Ranjit. The posterior urethral valve is quite common among the Indian population in Malaysia. So therefore, whenever someone calls me, the first question I ask, is it an Indian child? Male bilateral hydronephrosis. And I always tell my registrars in the neonatal intensive care unit, you see that, please examine the patient thoroughly. If there's any abnormal signs like bladder being palpable or the kidneys, then you put in the catheter in to drain while waiting for the surgeon. In fact, we did one extreme prematurity. We had to call in the pediatric urologist, and we did it the scope and managed to relieve the obstruction. The other question is that most parents, when I did hear Dr. Ranjit say that after the operation, the parents feel everything is done and they lost a follow-up. So this is where, when most often the posterior valve, when we say the valve has been ablated, they think it's all nice and rosy, and they go back home and they miss the follow-up. The important is that to the post discharge discussion with the parents, both the mother and the father, we need to tell the long-term outcome of posterior valve, what is expected of it. If any time
Yes.
they have fever, because urinary tract infection is notorious in the first year of life,
Yes.
and
Yes.
often
Very
they come
important.
in neurosepsis. So what we do in their cards, that we rewrite them, because sometimes the general practitioner or the emergency physician who bring the child in, they might say and give the antibiotic and discharge home. So we wanted to see them in the ward, because each urinary tract infection in the first year of life makes the posterior urethral valve much more difficult to manage. And I think the first year of life is very critical for these children, because we need to take care of their growth, their nutrition, and everything.
Yes.
So it's
Very
very,
true.
very important. So
Yes,
that's
very
one
true.
thing.
UTI is a very big bugbear. Of course, one condition I think I forgot to touch is that we must, I mean, as pediatricians, examine the back of the patient and look for any
Yes.
spinal cord defects. We should not be
Yep.
missing out on
Missing.
lipomenogenesis, secondary neural tube defects in general, which is neurogenic bladder.
And I mean, I'm not, and the other thing is that the neurogenic bladder with reflux, the most often, as you said, I mean, even the BUR, we should stay on with the medical management. Unless the medical management is not effective and failed, then only surgery. Because there are instances where people have reimplanted on a neurogenic bladder, which is the outcome is not going to be good.
The disastrous, not good.
Thank you.
Thank you.
Thank you very much. Sir, I would just like to add on to something and would ask you all. So these children who are born preterm, maybe around 35 weeks or 34 weeks, lot of times we see they pass very diluted urine, because the concentrating ability of kidney is not very good. And especially with PUV, if you have done fulguration, or in some severe cases where you require bilateral ureterostomy, these children, they actually go into a lot of dehydration because their urine is so diluted. So what is the time when they actually start concentrating urine? Like if it's a preterm 34, 35 weeker, like what age till we need to supplement them with IV fluids before they become okay and they can concentrate the urine? So most of the time we get a call from NICU that these children have high urea. The creatinine is coming down, but the urea is rising. So how should we actually manage these children? For how long? Should we supplement IV fluids? What are the features if they are gaining weight, but still if the urea is rising? Then what should be our treatment protocol in such cases?
Dr. Manish, what do you feel?
Urea, it is a post-operative case of posterior valve, I think you are talking about.
Our ICU. So he was born 36 weeker, 1.9 kgs, had PUV,
Right.
fulgurated bilaterally, because the creatinine was still on the higher side, around 1.5. So we went for bilateral ureterostomy. So now the issue is this child pours out so much urine that it is such a diluted urine that only
Yeah.
the urea is rising. The
Yeah, yeah.
creatinine is okay.
But again, this high urea creatine can't be very much reliable in these cases. But again, high urea and high creatinine, it does signify the underlying kidney disease. So I don't think even after fulguration, because the kidneys are so bad, so we won't be able to bring down the urea creatinine to the normal level. So if the child is passing, we do see such cases, and we do get referrals because of very high urine output. One thing is very high urine output. Another thing, hyponatremia and hyperkalemia also. So
Yes,
these are
yes.
features that we see the children are having post-operative, post-fulguration.
Yeah.
So
So
just
my my yeah, my experiences are actually the initial part of it is a post-obstructive diuresis, which you see, which is really severe.
Yes.
It will plateau out after some time. The child may still be little polyuric, but that is actually that permanent tubular damage which is talking to us. And then the management will be very straightforward. You lose fluid, you give fluid. If it's
right,
hyponatremic, give sodium, and so on. They may even be hypokalemic actually. They may even have
right,
or they may even have an RTA kind of a picture
right.
sometimes. And of course,
I
the
totally
medical
agree with
management of
you.
CKD, we'll have to do nutrition and the other aspects.
So with time,
I
these
mean,
symptoms subside. I think with time, with tabular maturity and with time, the polyuria also subsides.
Subsides.
Electrolytes also started normalizing with time.
So it all depends on where the creatinine is going to get stuck and how bad the tubular damage is. All very different case to case, I think.
Right.
Dr.
we
Selvakumar,
don't Yeah, we don't expect the creatinine and urea to come down immediately. The post-structive, relieving diuresis. The only thing is that if the child is in intensive care and needs IV fluid for other reasons, I will continue. If the child is otherwise well, I'm not keen on giving IV fluids. I would change the child to oral feeding if it's not supplemented by nasogastric feeding. That will take care of the caloric needs of the child, and sometimes, as we know, posterior retroviral, the salt losing and sodium replacement is very important. Even in a follow-up, we do continue and we monitor that. Most often, by the time they are 2 or 3, they do not need that. But it is very important to tell the parents that from experience that we don't expect a normalization of renal function in posterior retroviral, especially the urea and creatinine. We hope that, and then we need to follow them up. Actually, I was just reading an article from India, Dr. It is about how we expect the outcome of posterior retroviral. It's very, very important. We must prepare them adequately because preemptive transplantation is the best answer for posterior retroviral in the long term.
So I would request Dr. Ajay sir and Dr. Dinesh sir, if I think there are no more questions. Sir, are you there? Ajay sir?
Dr. Neha, I would just like to, I forgot earlier, with regards when Dr. Ranjit says the communication between colleagues is very important in your unit. If you're a pediatric surgeon or urologist, along with a pediatric radiologist, most often, if we can sit together, and especially your maternal fetal specialist, not to refer, often if we are over the cup of coffee or in the corridor, we can always meet up and discuss certain cases. My pediatric radiologist often call me and say, Silva, could you come and have a look at it? We'll discuss together. And in that sense, it helps a lot of picking up these difficult cases that doesn't conform to the classification, that it helps a lot. So communication is one thing is very important so that we don't miss the patients. The other thing is that it will be wonderful to have a combined clinic. Very few centers in my country we have combined clinic whereby the pediatric urologist or the surgeon together, the nephrologist sits together and discuss these cases, and the patients are given a shared decision. So this will be good. I think so. Thank you.
thank you.
Thank you. I think it was a wonderful session. We have already got so many messages, Dr. THERGAONKAR, from in our delegate group. They really liked the session. So I would just request Dr. Dinesh sir, are you there? I think they are busy.
Today is the
No
NRP
issue.
day. I think that's why IAPNs are busy.
Yes.
Yeah, no issue, Dr. Neha, I'm there.
Ravinder is there. So welcome, sir.
Yeah.
So pleasure to have you with us. So Dr. Ravinder, sir, you please take over. Sir is the treasurer-elect of IAP Delhi. and he's a very renowned pediatrician hospital, and also sir has a special interest in pediatric endocrinology. Welcome, sir.
Thank you all. Thank you, Dr. Neha, for again a very important and very good topic today. And thank you all our faculty, right from Dr. Manish and Dr. Salva, for your critical input, what you have said. Even in your country, you are saying that the mind clinic is not available at all places. Dr. Neha, what is the situation in my country? I think at big corporate hospital, we have a good team. What you say?
But in smaller places, I think even in the government hospital, little difficult to have. But I think opinion is the most important thing. Like I still call you for my patient and you call me for my patient.
Yeah.
I completely agree with Dr. Silva, right? We really need to have this because it is the teamwork that is most important. So I think picking them early really changes the whole scene. And we will soon have papers from all around the globe where we are picking up these children early, and the course of action of the follow up life, because I always believe quality of life is most important, which we are able to give these children, especially with a problem like PUV, where we are expecting more than 30% of them going into end stage renal disease. So early picking up really helps, sir. So that's what
Very true.
about.
I think, yeah, big metro cities, we have this age because, even in my hospital, uh, in our hospital, although, I mean, we don't have pediatric surgery and all that, but still, because we have so much a good liaison that we don't face much difficulty. So metro cities, Dr. Salva, situation is quite improved, and we are lucky to have a teamwork. For example, whenever I'm stuck up with any case, I just call up Neha, and Dr. Neha just immediately, give all the advices. Then, as per her advice, we go for further investigation, and most of the cases don't feel much of difficulty. But yes, these are the very planning process. Usually antenatal, second trimester and third trimester, always there's just a AP diameter is 3 mm or 5 mm, and gynecology is sent to us what to do now. I mean, these are the cases which we very frequently and very often get in our day-to-day office practice. I suppose same is the other people. So thank you everyone, Dr. Ranjit, Dr. Selva, Dr. Manish, all of you. And if there are any questions, Dr. Neha, in the chat box, you can take up that and give you the clarification.
Thank you very much. And just a bus take home message, please refer once at least for an opinion for any case of antenatal hydronephrosis to a pediatric nephrologist, because that can give you a really insight on to how to deal it in future. So I think that's the most important take home message for everyone here.
Thank you. Thank you.
Thank you.
Thank
Thank you.